All right. So we're gonna cover in this one just tuberculosis, pleural space, and a little bit of ABGs. Um, yeah. So this is the next half of it. It should go a little bit. It should go pretty quickly because it's half of the full lecture. The other half was done yesterday, and the recording is there if any of you missed it. If any of you needs the PDF or doc, just let me know. I can give it to you anytime. The main thing with the tuberculosis is that there's a lot of patho. You don't really need to know all the patho. So I'm just breaking it down into the very basics and then focus so we can focus more on the more important stuff that you need to know about TB. So this picture here is a pretty good showing of how tuberculosis develops in the body. You are It comes from this bacteria, the Mycobacterium tuberculosis. You breathe it in through aerosolized droplets. So one of the things that no, there's different types of droplets. So some of them they get coughed out and then they just make their way to the ground. Some of them they get coughed out and then they stay in the air. So they aerosolize and stay in the air. And that's what happens with TB in particular, as opposed to like pneumonia, which um, the particles are too heavy, they don't stay in the air and they fall down. Um, that was like a big debate when it came to COVID, whether it was a droplet or an airborne. So sometimes they found that the COVID droplets could aerosolize and stay in the air um, and whatnot. But essentially, you're breathing that in, it makes its way to the alveoli, the bacteria does. Your body then tries to encapsulate it. So here you have the bacteria. Your body then essentially makes this granuloma to kind of cover it, kind of like an abscess. Same kind of concept. It's surrounding it and trying to keep it in bay. But the tuberculosis is able to survive here and essentially become dormant, meaning it's just kind of inactive, but it's still around. And after certain situations, such as taking immunosuppressants or having a lower immunity, where essentially the defenses are no longer up, it's able to activate again. Here, he mentions, the caseous necrosis, like a cheesy, little nasty, um, little little necrosis happening here. So the cheesy liquefaction, that's what that's essentially what happens when it starts to activate. All right. That's pretty much all you need to know about a patho. If you even need to know that, it's maybe a little bit extra, but you kind of get the general idea. It gets breathed in, your body kind of half-asses it, and then at some point, depending on meds and immune system, it might reactivate. Okay. We talked about this a little bit, but TB out of your standard, contact, droplet, airborne, which one is it? And then what do you do for it in terms
Airborne.
of, yeah, so it's airborne. So what does that mean?
N95.
Yeah, you're gonna wear the N95. Negative pressure room, yes. So N95 patient's gonna be on a negative pressure room. Cool. And at least here in nursing school, we can't go into any of the airborne ones, even though they give us a fitted mask, but we're told not to go into any of the airborne, so it's kind of interesting. So I don't even know why they make us fit into the mask. Um, yeah. So then what are some risk factors when it comes to tuberculosis? So there's like a few that get mentioned, and a lot of that can kind of go along with general like infection stuff, risk factors for infection. So homelessness, yeah, so people that maybe are gonna have like a weaker immune system, worse diet, living conditions, yeah. So especially that, so the drug users, especially IV drug users, yes, immunocompromised. So that can include HIV, people on medication. So maybe things like autoimmune diseases, they take immunosuppressants. People with rheumatoid arthritis, they can take methotrexate. Mentioned crowded environments, so living in like a prison or uh living military barracks or whatever. What else did you guys mention? Oh yes, so poor people essentially homeless. Yeah, I like so it's like combination of poor diet, weakened immune systems from uh just not having ability to access pretty much anything. Crowded environments were mentioned. I would say alcoholics too. That kind of also alcoholics. Yeah, yeah, yeah. Immigrants from other countries. I just found it funny though that on the I found it funny though on the PowerPoint they grouped immigrants and poor like together. So it was like poors and immigrants. It was just like the as one bullet point. I was like, damn. But yeah, that's pretty much it. I mean, obviously there's obviously there's some nuance between some of these, but a lot of this kind of goes together. So this can also be from weakened immune system. So in general, you see that a lot of it comes from weakened immune system, weakened immune systems. Immigrants, poor people. That kind of goes with the. I mean, it doesn't necessarily have to go with the homeless. Uh, Poor socioeconomic status. All right, a lot of it kind of goes from lack of access to um food, access to healthcare, so poor nutrition, weakened immune systems, alcoholism that can cause difficulty with absorption of vitamins and stuff. Crowded environment, just because you're going to be next to people, they might be sick. So, and then another one that I know nobody said, but I know you guys would pick it in a SATA is just those that have been in close contact with someone that had active TB. All right. So pretty self-explanatory on a lot of these. Main thing to know, of course, is going to be this. Gonna know it's airborne. What does that mean? Some of the risk factors might be good to know. What are some of the manifestations? Again, you could always get those SATAs. Pick every sign and symptom. Yeah, yeah, blood tinge sputum. So emphasis on like the blood tinge part. So you can have like um, like a full on bloody, like basically the difference between blood tinge sputum and like coughing blood, I guess. Yeah, the night sweats are a big one with this one. Night sweats, obviously that comes from coughing. So you'll have coughing, you'll have potential blood tinge sputum, you'll have maybe mucousy sputum, fatigue and weight loss. Yes. Yes, yes, yes. Yeah, I think in here he kind of put it like dry, purulent, or blood tinged, and then I don't know if he specifically like said hemoptysis, but um like full on coughing of blood is probably a little bit more like a pulmonary embolism, and blood tinged sputum meaning it's like a bloody sputum. So it's not just like full on blood, it's like got some mucus, some of that sputum from the lungs. But yeah, it's tinged with blood as opposed to like full on I'm coughing just blood, That's what I mean. And another one would be kind of specifically like a low grade fever as opposed to like a high fever. And there's like another one called a scrofula, which is kind of like a swelling of like lymph node swelling. So that's like a potential thing with it's like some infections, they can swell up your lymph nodes, and that can be like a sign that the infection is going to be worse. The swollen lymph nodes. But I would say this is important. The night sweats and coughing, of course, and the low grade fever as well. Probably like the most important things. Probably also the fatigue. probably the stuff that comes up the most. All right. And then for the diagnostics, there's like three main ones that get done. There's like maybe like another one, but these are like the main ones. And they serve different purposes. So what do you guys know about the PPD? Size matters. Yes, so it's a skin test. There's induration. Yeah, this one essentially tests for exposure. Exactly. So this one will not tell you if there's an if it's been active or it's an inactive. It will essentially just mean that there has been exposure, and at the very least, it could be active or inactive, could be latent. Yes, so PPD, it's a test for exposure to TB. Um, Positive equals exposed, essentially. And here, yeah, exactly. So perfect. So if it is positive, it means you've been exposed and you need a chest X-ray to rule out active TB. So I'm sure some of you guys, I mean, we need to get the PPD. I'm not sure how often you guys get them, but yeah, once a year. I had to get more than once a year because I was born outside of the US. So like even like for work, for tutoring, they made me do, I did one over the summer, like last summer, and then I had to do another one like 6 months later because they wouldn't accept my previous one because I was born outside of the US. So and it's in a high risk area. So they made me do another one. Yeah, I got the vaccine too. That's the thing. I'm vaccinated. I have the little mark on my shoulder. Yeah. I mean, I've never had it. The BCG. That the name of the vaccine? Yeah. But yeah, they made me get it. They made me do the PPD twice in a year. But that's neither here nor there. So yeah, test for exposure to TB, positive equals exposed. And I think it's good to know also that's also true for the people that took the BCG. Oh, you want me to write that? That is true. We could write that down. I actually don't get positive PPDs though. Mine don't show unless I'm thinking of a different vaccine that I took from the. Yeah. But yeah, for those that received a BCG vaccine, they will. Yes, I think it's good to know that. So I have a picture here that is good for that. So here is the general guidelines for this. So, and this is all about the induration, not so much the redness or the inflammation. It's how much is raised. So that's the key thing. It's how much is raised. That's what you're measuring, not just the redness. Mine show up, mine shows up like a red area, but it's not any. There's no induration on mine. But 15 millimeters or more, general public without risk factors would be considered positive. 10 plus would be people that are at a bit of a higher risk. So those that come from long-term facilities. So see how your risk factors come up. IV drug users, medically underserved population. So that can include people of poor socioeconomic status, maybe immigrants as well, and then healthcare workers. So technically that includes us. So 10 plus would mean that we're positive. And then 5 plus would be for people that are HIV positive or those that have been in recent close contact with active TB. But it's also worth noting that so it does mention here HIV positive, but if somebody has AIDS, they might they might have TB even with like a zero in duration because their immune system is so messed up that it doesn't even react. So that's a possibility that someone with AIDS and the PPD shows 0 might still want to be treat them as if they had tuberculosis until you can rule it out with the other test. Okay. So yes, I would think the difference between these can be good to know. All right. But yeah, so once they do this one, they can, and it shows that positive finding. They do a chest X-ray to rule out any active tuberculosis. So that's the purpose of the chest X-ray. It's there to do kind of assess for like I think they say the lesion, so they would be able to see some evidence of that cheesy liquefaction and damage and stuff, infiltration, consolidations and stuff. But we're not the ones interpreting that. So just kind of know that this is there to rule out active TB. And then someone that does have TB, I think someone already kind of talked about it a little bit like back. The cultures, yeah. So the sputum AFB, I think it's acid fast bacteria. This is the definitive diagnosis. And they do this 3 times. So they do a 3x. And when are they considered non-infective? So yes, you need to have 3 consecutive. Yep, negatives are required to be considered non-infective, and this is the definitive test. So, and any positive result equals infective. Consider contagious. Alrighty. So that's gonna be your key things to remember, and you guys gonna get the general flow of how it goes. It's gonna go here first, here, and then here, typically. Just kind of like the general flow of how they do things, so they're not just going straight for this one when they might have been able to just do this, I guess, and stop. Some other ones that might be only the sputum culture would diagnose TB. Like a definitive one, yeah, I would say. Well, although it is a lot of time done um for like contagiousness and stuff, because the chest X-ray can already tell you if you have TB. So kind of the combination of them. People can look at this and be like, it's active TB, and this one will tell you if you're contagious or not. But it's also technically a more definitive test in general. Like this could be like it could be um that you see this, you think it might be tuberculosis, and it turns out maybe it's something else, damage from something else. But they will look at this, see if something is iffy with it with the chest X-ray, and then they'll do this, and this will for sure say one way or the other. But if there's nothing shown on the chest X-ray, they'll just stop there. Anything else would maybe be like a bronchoscopy gets mentioned. You can use that, kind of check things out, collect sputum and stuff. But these are going to be your main 3 things to think about. But yes, conclusive evidence is just to the sputum. Um, and in terms of the management, there's maybe some general guidelines, but a lot of it is a bunch of different medications and stuff. But what's some of the educations you'd want to teach a patient when it comes to the TB medication? And then we can go into more detail about the TB meds later. Yes, so strict adherence is going to be probably like your biggest thing. And that kind of just goes with antibiotics in general, but you don't want to create like super TB, like giga super TB, right? Yeah, so avoid anything that can lead to hepatotoxicity. So avoid alcohol. Um, watch out for signs and symptoms of hepatotoxicity, essentially. But alcohol or hepatotoxic medications, because a lot of these medications end up affecting the liver, and yes. So take with a full glass of water. Um, and in general, get good hydration, flush out uric acid. What else? Some of them can cause that, yeah. So some of them, the education would be that you might have orange fluids happening. Risk of, yeah, because some of these can cause gout as well. We've already mentioned report jaundice and something, yeah, the fam can cause the orange urine. Okay, jaundice, bruising, because you remember your liver stuff can cause reduced coagulation factors and stuff. Protective clothing. Yeah, so yes, yes, yes. Because some of them can cause like photosensitivity. I think so. I think so. EMB, E for eye. That's how I remember it. EMB, E for eye. Uh, P, yeah. Yeah, P for photosensitivity. Yep. And then if there's anything else that I think is good, is just tell them wear a mask until your infection is officially considered not contagious. I equals I am hungry and can't move my hands or feet because you're one that take that man on empty stomach. That's an interesting one. Is that for the isoniazid? Yeah, he'd take it on empty stomach. You can get pregnant on these meds. Yes, that's another thing. Yes, yes, yes. Yep. And then we can break a lot of that down into the antibiotics, but that it's good to know. Definitely these two for sure. Like you definitely want to make sure that that's done. You need to be sure that kind of goes with the hepatotoxic stuff, jaundice and stuff, where mast until infection is considered. These are probably like the most important things to keep in mind. Yes. So here we can just kind of break them down. Isoniazid, that's your INH, and that one is taken, I think for a full year. We already, I know some of you guys right now, you mean in the comments? I think right now this one was just kind of general stuff because a lot of these can be kind of broken down into general stuff. And then we'll go more specific. So here we are. A lot of you already mentioned take on an empty stomach to absorb better. There's a risk of peripheral neuropathy, so it's good that you guys know these meds pretty good. And how would we work with that? Oh, someone already mentioned that. Good. I kind of already started writing it. I'm like, oops. Risk of yeah. So take vitamin C to reduce vitamin C. Sorry, vitamin B6 to reduce the risk. Yep, yep, yep. B6. Which one is that? So B9 is folate. B12 is cyanocobalamin. B6 is which one? Which one is B6? What's the government name of that one? Peroxidine. Paradoxine. Okay. Pretty sure they're not gonna bring that one up, but just in case. Yeah, but vitamin B6, and again, it's toxic to liver. So that's kind of the one of the common things with all of these. So probably these two, well, actually all three of these points are very important to know. You need to for sure know isoniazid. But the key, I guess, the thing that makes this one unique is the peripheral neuropathy and maybe taking on an empty stomach compared to the other ones. A lot of the other ones you can kind of cluster down. So then there's rifampin, which is another one that take for a full year. And you guys already mentioned it. This one can turn bodily fluids into a red, orangey kind of color. Yes. And this is normal. It's a normal, non-malicious side effect. Yes. See if there's a funny, is there a funny way to remember that? Rifampin. I can't think of one. But yeah, this one, you can get pregnant even on the pill. And again, this is toxic to liver. So the unique things with this one is this. This is unique. This one's also one of the important ones to keep in mind. This is something to keep in mind. We already talked about this is kind of a lot of them do that, so you can kind of just cluster them together. And I guess this is like its own unique thing here. But you guys know these pretty damn well, huh? And there's the ethambutol, the EMB. This one's for the first 2 to 3 months. And the ones that are not the full year, they're all the first 2 to 3 months. Your baby's name will be your phantom. I think that's how I remember it. Oh shit. I like that. Yeah, so this one I think about E for eye. So this can include optic neuritis risk. So you want to monitor for vision change. But it's worth keeping in mind that once they stop taking the med, usually your vision problems will be reversed and your vision will return. Yes, it does do this. And then let's see. Once medications stop, issues with eyes should stop as well. We talked about this one can increase the uric acid. So you gotta drink plenty of fluids. We talked about that before. What medication would you give for high uric acid? Yes, so take allopurinol and plenty of water to flush it out. And yeah, alcohol can cause nausea, vomiting, but the main takeaway would probably be this stuff here for this medication and this stuff here, as well as knowing the time frames. So the good thing about the time frames is out of your medication, you have two that are take for a full year, and then the other two are going to be for the exact same time frame of first 2 to 3 months. Um, both of these that already have this thing in common also have the toxic to liver thing in common. Um, the uric acid thing, ethambutol has in common with the other medication, the pyrazinamide, PCA, which is also taken in first 2 to 3 months. This one again increases uric acid. Has a lot of drug interactions. P for photosensitivity, so you gotta wear sunscreen and protective clothing. And this one monitor for hepatotoxicity and gout. So this one causes a little bit of both, but the unique thing is this one. I don't think they specify if it is or isn't. Um I think in actuality, I think they all are though. But I think it's ethambutol is less so associated with it and more so associated with this. But I personally just cluster it all as liver stuff, potential gout stuff, and I just keep in mind the time frame and keep in mind the special like some of the unique stuff like the peripheral neuropathy here, the orange fluids here, E for eye, P for photosensitivity, and I cluster out the rest of the information. Um, and that's pretty much it for tuberculosis. Anything, any questions on anything? No. No, you don't need to know that. Any other general information? Oh, maybe I can add this. So for some general information, if someone thinks they were exposed, they can take INH for 6 to 9 months. The radiology route. Yeah, you don't have to worry about that. Yeah, don't worry about that. Maybe in 240, there's gonna be one thing where like they want you to know what it looks like on an X-ray, but I don't think they really not for this one. I think they're exposed to INH for 6 to 9 months to avoid infection. I have a question for you guys. Did he ever mention anything about like if someone's homeless, how would you get them to take their meds? All right. Yeah, he said that for a reason. Yeah. Yeah, he said that for a reason. So just keep that in mind. So yeah, the DOT. hmm So that stands for directed observation therapy. So you're going to be monitoring to make sure that they actually are taking their stuff. So the idea would be if the concept there, if there's like a homeless person, you can essentially bribe them, be like, take your meds, we feed you. So he said that for a reason about the homeless guy. No surprises will be there. You'll know when you know. You'll see it when you see it. But yeah, any questions on TB? All right, perfect. So now here, I think definitely one of the most important topics is going to be a lot of the stuff dealing with general pleural space and pulmonary embolism. I think this is going to be one of the most important topics for the test. So pulmonary embolism is going to be when there's air, blood clot, or fat that launches for essentially gets stuck on a large pulmonary vessel. Uh, uh, uh. Yeah, DVT is a common cause. Someone has like a long bone fracture that could cause a fat embolism, that can cause a PE. Air embolism can cause a PE, but the clot, DVT, so that your focus is on stuff. Basically, your focus is a lot of stuff dealing with DVT, so that's why it's important to know some of that stuff there. So some of your risk factors, someone basically anything, essentially stuff that can cause DVT. So same as DBT, essentially stuff that causes DBT. I guess we can list some of them down. Yeah, immobility, that's a big one. Oops. So immobility, so what's an example of an immobility thing? Being bedbound, long flight from China or whatever he mentioned. Post-op, yeah, bedbound, like a post-op, yeah. Not moving around much, like me right now, because I'm on the computer for 2 hours. Yes, exactly. Other risk factors that you guys can include, we said post-op. What else can you guys think of? BC, before Christ. Uh, wait, what's BC? Oh, birth control. Yeah, so birth control, oral contraceptives. So that can be another risk factor there. Smoking, for sure. So the oral contraceptives, a lot of them are like estrogen and progesterone. The combination of smoking and BC can probably, yeah, the combination. Yes. So pregnant women, yeah. So if you guys remember from OB, the concept behind oral contraceptives and how they work is that they essentially trick the body into thinking it's pregnant. And when the body is pregnant, it becomes hypercoagulable because it's expecting to lose a lot of blood once you give birth. Well, not me or you. Well, not Ryan, because he's the one that mentioned it, but not him. He doesn't have a uterus. But that's the concept. So the body is preparing itself to lose a lot of blood, so it becomes hypercoagulable so that it doesn't bleed out once it gives birth. So that's the reason why oral contraceptives can make you have higher risk of clots. Yes, chemotherapy can also increase risk of blood clots. So if you recall, so it does cause like pancytopenia, but if you recall, one of your potential complications is DIC. So it can cause um, expenditure of all your clotting factors by making like a lot of little clots. So DIC is not just you see like it's not just like a loss of platelets, it's also microclots. It's a combination of your body reacting to something, usually like an inflammatory response. It will then have this massive clotting cascade. Yeah, so that's why you might think with the DIC, you might think the heparin might be contraindicated, but it can be actually something they do for DIC because depending on the patient condition, their problem will either be the bleeding or it will be the clotting. So if they're currently not bleeding and those clots are causing problem, they'll put them on like a heparin drip. Uh, but if the bleeding is the problem, they might do like a fresh frozen plasma or something. But yeah, chemotherapy is one just because of the risk of like DIC and stuff. You can have microclots. We talked about oral contraceptives, especially when smoking. Pregnant women because we talked about how the hormones affect the coagulability status of the person. We already mentioned like the different types. So there's the fat embolism. So fat embolism most common from long bone fractures. So like a femur fractured, you gotta assess for your acute compartment syndrome, assess for signs and symptoms of fat embolism, which is basically the fat embolism leading to a pulmonary embolism. So a lot of respiratory assessments there. What's something else? Uh, we talked about air embolism. So where can that come from? Yes. I think more common with the removal than insertion, but yes, the central lines, especially PICC lines. Remember when the PICC lines are supposed to measure the circumference, assess for clotting and stuff. So the CVAD removal. So that's due to an air embolism, and as well as yeah, chest tube might cause like an air embolism. So like a chest tube can cause air embolism. So that's why you don't want the air leakage because that's what that could happen. That's what that could cause. Blah blah blah, pick lines. So that's why you measure the arm circumference and stuff. But a lot of different stuff to keep in mind. Um, yeah, cool, cool, cool. Oh, another one that didn't. There's two. If you don't use it, you get DBT. Yeah, yeah, yeah. Yeah. So yeah, in general, just think of things that can lead to clots. So there's actually two things that I don't think got mentioned yet. I don't think it comes to us immediately. It's not like a instant thing like, oh yeah, it's this. So kind of, you know how like they call things blood thinners? They're not actually thinning the blood. Um, but ironically, you can have like more viscous you can have more viscous blood. Um, and the viscosity of the blood, what can that come from? I don't know if I'm saying that right. So if blood thinners help to prevent clots, what makes things more viscous? The dehydration, yeah. So your hematocrit, when you're dehydrated, your hematocrit goes up, meaning that your concentration of blood to fluid is higher, more concentrated. So that makes your blood less liquidy, essentially, more viscous. more likely to clot. So dehydration can be a big one for that we might not immediately think about. Uh, yes, due to hemoconcentration. And then there's one more. I don't know if anyone's gonna remember this. So a heart condition, not a heart, I guess not a heart condition, but like a kind of a heart thing that leads to clots a lot. Yes, your AFib. So it is more likely to cause like stroke and stuff, but it can also cause pulmonary embolisms and cause MIs and stuff. But it's your AFib. So all of these things to take into account. A lot of these things kind of just go with general clotting. Yes, so that's why that people with AFib are typically on Coumadin or Eliquis. I think Eliquis is more common now. Yeah, aspirin too. They can be on aspirin too. Although I believe let me think about I think for strokes, aspirin is more effective. And I think because there's different types. So the aspirin is an antiplatelet. The Eliquis and Coumadin are anticoagulants, and they technically have different advantages for different clots. hmm So some of those are actually more effective for different types of clots. So I believe for venous clots, the anticoagulants are better, and for arterial clots, the antiplatelets are better because a lot of your arterial clots will cause problems due to excessive platelet activity, but a lot of your venous clots um, are caused by more like an embolism kind of thing. So that's why your DVT causes pulmonary embolism. But your AFib's more likely to have issues with stroke, where a lot of the time that can be caused from like too much platelet activity. So it could be kind of like gets the clot happens and then the platelets overact and cause even more issues. So which is why um, the aspirin is helpful as well because that one is a little bit better for like arterial clots. And none of this is relevant to anything. I'm just kind of saying information. You don't need to know that. I'm just kind of saying information now. Um, all right. But yes, so just keep all these in mind. They're important. Anything that you think would cause DBT, think about it because DBT can easily lead to the pulmonary embolism. Because if that clot goes from your venous, it's gonna come back into your heart, and the first place it's gonna go after it makes it through the right side of the heart is back into the lungs. Okay, so what about some manifestations? And I'll have a picture that comes with it after. But here are some things that you should be able to use to differentiate it from other stuff. Yeah, so especially you have some things that are like sudden onset. So you mentioned the tachypnea, tachycardia. So you'll have sudden instance of tachypnea because all of a sudden you have a large pulmonary vessel that is being uh, completely clotted off. So your body's going to try to compensate. So you're always thinking about compensation in general. Pleuritic chest pain. So that's pain when you're breathing on deep breath. So the pleuritic chest pain for sure. Shortness of breath, sense of impending doom. Yes. Yep. Some other things that you might see is the hypoxia. So, if you're not getting that good oxygenation, the hypoxia, you can have crackles. Yeah. So the pulmonary embolism cause a collapse of the alveoli. So you can have crackles due to atelectasis. Due to atelectasis related to the collapse of alveoli. Neck vein distension. So that would be yeah, like a consequence of like a right-sided heart failure. So that'd be like a JVD. So JVD related to right-sided heart failure. Hemoptysis, yeah. So this one is essentially like full on you're coughing up blood, and that's actually a key sign to um tell apart some of the things. So that's coughing with blood. Because some of these can be very similar to some of the other ones, like a pneumonia or like a tuberculosis and stuff. So very similar, like on the acute sense, but the hemoptysis, like purely coughing up blood versus like sputum, like a mucousy blood tinged. That can be the term, like the some of the one something that you can see. And I know that this one can also have low grade fever. So again, that's like a reason why they might be confusable. Because pneumonia is not pneumonia, sorry. Tuberculosis can also have a low grade fever as opposed to like a high fever. So these can look kind of similar. Something else that gets mentioned is the blood pressure. So what do you guys think about the blood pressure? Yeah, so long term it's going to be a hypotension, but you might initially see a hypertension before it goes to hypotension. But long term it's going to be a hypotension. Uh, you'll have compensation at first. So it'd be kind of like a hypertension that then overall becomes hypotension. So it's like acute hypertension into more long-term hypotension. Yes. Yes, 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 yes. Same logic behind that one. You are compensating so much, you get initially alkalotic before you become acidotic. Exactly. And I also have this picture that I think pro was also probably in the lecture. But I like this picture. You got that sudden sharp chest pain. Here's showing you like the DVT. It's like a little car about to make its way over there. Some of the risk factors are mentioned here. It kind of shows your ABGs as well. Hemoptysis here needs O2. This guy's on a heparin drip because that's going to be one of your managements. I don't know, but I guess right here, 2007 Nursing Education Consultants Inc. Because these come up a lot. They really do. I kind of like them. I kind of like them though. I feel like they help me remember. Here you can see the cyanotic on the feet and stuff. Yeah, I mean if it's good, it's good. I guess it like yeah, 2007. If it's good, it's good. Hmm. All you guys were alive in 2007, right? I swear some people. I think the youngest person in my cohort is like 21. What? Jesus Christ, no way. Okay, hold on. I'm gonna calculate your okay. Wait, I was about to calculate your age. I'm like, what the hell? Okay, yeah, that's impossible. All right, we're chilling, we're chilling. I was about to calculate your age. I'm like, oh shit. Is she actually? No. Wait, no. I'm getting trolled right now. I mean, if you're like super crazy advanced, you can do it. Yeah, you can test out of high school at like 15 or 16. I think 16. You can test out of high school at 16, and then you could have done your prereqs in a year, and then you could be here, you know? But yeah, I like the picture. It helps me. Then there's a bunch of assessment stuff. A lot of stuff here that I wrote down that we can. Oh no, it's crazy. I don't know. It's kind of funny. Kind of reminds me of like the jokes where it's like I shouldn't have been playing in the playground when I was 7. I should have bought a house, kind of thing. Yeah, but what are some things to assess here? I'll give you lungs because that's pretty obvious. Yeah, heart, lungs, vital signs and stuff. The lungs, you're definitely gonna assess the sounds, the heart sounds. Well, assert the lung sounds. Some interventions you can do. We're gonna do, I guess that's intervention. So we're gonna definitely place the head of the bed up. Try to give them O2 if needed. O2 supplementation. If possible, we might need to intubate if like they're not actually because sometimes with this you can have I guess it'd be here. You can have a VQ mismatch. Assess level of consciousness, of course, perfect. So assess for level of consciousness. It's always going to be important. Your vital signs. Um, so overall, your vital signs can show increased heart rate, increased respiration rate, decreased blood pressure over time. Like that low grade fever, you can get all that. With the heart, yes, pleuritic chest pain, I like it. And of course, with the chest pain, you always got to rule out if it's, some heart related stuff. And now we already kind of slightly talked about it, but if you're having a pulmonary embolism over time, you have stuff uh pooling up, and if you have stuff pooling up, it ends up causing um a lot of pressure in the lungs, the pulmonary hypertension, and pulmonary hypertension can be a cause for a specific type of heart failure. Do you guys remember yeah, so the right-sided heart failure, it's called the cor pulmonale. So cor being Latin for heart, pulmonale meaning related to the lungs. So that's where that name comes from. So the cor pulmonale. This is the right-sided heart failure, and this is related to a pulmonary hypertension that's due to um, that pulmonary embolism. So that's where that comes from. And we did talk about it right here. No, right here. The right-sided heart failure. Uh, yeah, and the reason this one, we associate left-sided with like the pulmonary embolism, but a lot of your lung stuff can actually cause the right-sided heart failure, which is why it was called. This one had the name um, lung heart essentially. So another condition that can cause right-sided heart failure um, can be something like a COPD. COPD people can get right-sided heart failure due to pulmonary hypertension. So that's where that name comes from, if you were ever wondering. Yeah, if you're having hypoxia and stuff, how did I not include this? But yeah, if you are having issues with your SATO2, you're gonna have altered level of consciousness. And if you're having altered level of consciousness, and not getting enough oxygen, what do you think could happen to the heart as well? Yes. So it might have arrhythmias, and those arrhythmias can lead to um, different things. So you can also get an MI for sure. Arrhythmias is also possible. You might just get straight up like a cardiac arrest, um, which is not the same thing as an MI, but you can also get like a cardiogenic shock. So that would be complete pump failure. So arrhythmias, cardiogenic shock, and you don't need to know specifics on arrhythmias or cardiogenic shock. I think just know that it can occur. You'll learn this in the critical care next rotation for you guys. So this is pump failure, complete pump failure, arrhythmias, and yeah, all this stuff can lead to all that stuff happening. Something else to assess might be not bad to look at urine output because one of the complications can be a cardiogenic shock. So you want to assess to see how the body's going, like the body's going into shock, cardiogenic shock. You can a lot of the cardiogenic shock in terms of the the stuff you guys know, that you guys have been taught. is pretty similar to the hypovolemic shock, other than like the treatment, but you'll have a lot of the same symptoms. But the main treatment for the cardiogenic shock is like um, ionotropes and vasopressors and stuff, as opposed to fluids. Fluids won't really help as much. But yeah, again, don't need to know much about that. It's just more information for you guys. Let me know if anything's confusing, because sometimes I just yap. So something I want to keep in mind for the O2 supplementation is that if that they're desatting, you're desatting, I guess that's how you spell it, then you're gonna want to move on from, you want to bridge, but at some point, if nothing's helping, then you're gonna go for a, yeah, 100% non-rebreather. And sometimes that might not even help because specifically when it comes to their VQ scan, there might be a disconnect between their ventilation and their perfusion, and this patient might actually not get any benefit from O2, and they might actually need to be fully intubated. Yes. Yep. So like a pulmonary embolism can be one of the things that can lead to um, acute respiratory distress syndrome, in which case that O2 supplementation is not really helping, and they will need to be intubated and stuff. And again, more information, more detail on this stuff to come in the next rotation, but that's just kind of the some of the general stuff to think about with that. Some other stuff here. Oh, I guess I already have that here. But if there is, then think about like, uh, he mentioned 2 to 4 liter per minute. But of course, if that's not helpful, I guess I'll just put it here because we already have it. If that's not helping you advance from wherever you are, 100% non-rebreather, um, call RRT. You might have to get like the ambu bag, and manually bag them, wait for them to get intubated and stuff. So why do we do a chest X-ray? So just to say, a chest X-ray will not show a pulmonary embolism. Yes. So a lot of things, sometimes a chest X-ray is just done to rule out things. So sometimes people coming in with chest pain, shortness of breath, they'll get a chest X-ray, just as just to rule out if there's anything else happening. Maybe the chest pain and shortness of breath came from a pulmonary reason rather than a heart reason. Or maybe there's two things happening at once. So the chest X-ray is to rule things out, especially because some of these signs and symptoms can be very similar. So again, like these signs and symptoms can look a lot like that tuberculosis, or they can look a lot like a pneumothorax. That's the acronym, pneumothorax. And yes, 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 yes. ABGs, you already said it. Initially, it will be respiratory alkalosis due to hyperventilation when compensating, will end up being respiratory acidosis due to poor perfusion, poor oxygenation. And like you said, the VQ scan, this is what's going to really diagnose diagnose pulmonary embolism. So the VQ scan is diagnose PE. It's going to show perfusion and ventilation, and it's what's called like a mismatch. Yes. So you will have ventilation, meaning that they're able to breathe, they're moving their chest up and down, but they're not able to actually get um, that exchange of oxygen with the blood um, because of that blockage in the artery or the pulmonary vessel. So you will see that space, ventilation without perfusion, essentially. Yes. Yep. So here's I have a picture of a VQ mismatch. It's not for a PE, it's for a pulmonary edema, but it gets the general idea across. It gets the idea across, even though it is not quite the same thing, but it gets the general idea across. Here, the pulmonary edema, the lack of the VQ mismatch is due to fluid in the alveoli. But um, in the case of a PE, there would be occlusion, so it wouldn't be able to exchange because of the blood flow being impeded, as opposed to like the fluid causing issues. But it kind of gets the general idea across, I hope. Where here you see a normal alveoli, it's able to properly exchange. And again, this is for pulmonary edema. Here, the fluid is preventing the exchange. Imagine instead it was the PE, then you would just not have as much blood flow going on, so you're not really getting that exchange. But that's kind of the that concept behind the VQ mismatch. And the spiral CT is also used to diagnose the pulmonary embolism, but it's also not as invasive. What are some things to keep in mind with the spiral CT? Yes, so with the this one's going to use a contrast. So assess, well, I guess check for allergies to iodine or shellfish. Yes, this is where I said like before that he loves talking about mucomist. Yeah. But yeah, we can pre-medicate with Benadryl, Solu-Medrol. They'll do. Actually, I had a guy that was allergic to shellfish. He had to get a contrast CT scan with contrast. I gave him Benadryl IV push before we send him out. And then after he got his CT scan, we send him back to jail because, well, I guess the jail unit. We send him back to the jail unit. Yeah, he likes it a lot. But this is a key thing to keep in mind that that's something to keep very much in mind. Monitor kidneys because the contrast is nephrotoxic. It does, it really does. Can also be used for Tylenol overdose. Monitor kidneys, contrast is nephrotoxic. Can pre-medicate with mucomist to protect kidneys. Cool, cool, cool. So fibrinolytics. So what does that mean? I guess I should put assessment management. I guess that's the management. So what is an example of a fibrinolytic? And what does fibrinolytic mean? The clot buster. So what's a clot buster? Yes. Yes, yes, yes. So not to be confused with your heparin. Heparin is not a fibrinolytic. It's an anticoagulant, so that one would go here. Specifically a heparin drip. The fibrinolytic. So this is a clot buster. So this is done if there's like a huge pulmonary embolism. Example of these would be the alteplase, the TPA, um, urokinase. And of course, what are the risks involved when it comes to a clot buster? Yes, so we're gonna assess for bleeding, hemorrhagic stroke, all that good stuff. Injury and bleeding. And so you're gonna monitor for vital signs, bleeding in general, like mental status, because altered level of consciousness can be a sign of bleeding. Yes. So we're gonna also assess for bleeding that could be in the urine. It could be anywhere really. It could be a swollen belly. So maybe the abdominal girth is bigger because they're bleeding internally. That could be a sign. In general, you want to be, yeah, you want to really be careful with that. You don't want to make sure that they're safe and stuff. Fall precaution sounds like a good idea. Just if they fall, it's probably over. I could just imagine like they fall and they just explode like a little mosquito or something. Not really, but but then there's the heparin drip. So what's this one for? If it's not gonna break the clot up, what's the purpose? Yeah. Yeah, this one's gonna prevent the clot from getting bigger. So this is done for the PE. It's done for also like an MI if they're not able to get to the cath lab in time. Heparin drip can be the person can be on a heparin drip. And the heparin drip, yes. So this is going to prevent an increase in size of the clot or the formation of more clots. But in general, the difference between subcute versus drip heparin would be that your subcute heparin is given as a prophylaxis, but a heparin drip is given um, for an active clot. That's the given for active clot. And Josh says DC wants therapeutic range 2 to 3 you can see on Coumadin. So referring to the INR. So that's kind of the bridging of heparin to Coumadin. So Coumadin takes a little bit to get going. So someone like this that would be on a heparin drip would get heparin beyond the heparin drip and also be placed on Coumadin until that Coumadin gets to that therapeutic range, in which case then they will DC the heparin drip and then beyond the Coumadin, um, just maintain on the Coumadin. But the heparin drip, what are we assessing? What lab are we assessing for that one in particular? Yes. So PTT/APTT and platelets. So the reason we're assessing for PTT is that's going to be the main uh, that's how you're going to titrate it and stuff. Yes. So your normal PTT is like around 35 to 45. On a heparin drip, it should be about close to 2x. Jessica, it probably depends on their condition, but some of these people, after they have um, like a PE, a stroke, or an MI, they will probably be sent home with some sort of anticoagulant to prevent this from happening again. So people that have PE, you'll probably see in their history they take Eliquis. Um, so they were probably bridged on that heparin, like they were on heparin until they hit the therapeutic range. No, just the PT. The anti-XA is how the heparin works. That's a specific clotting factor that it works against, but don't worry about the XA part. I don't know if you've ever done like a med S bar and had to look up Lovenox, they'll be like, this is a anti-XA, whatever. But don't worry about it. Just worry about the PTT. Just know that you want it to be around two times more than the normal. So PTT should be about 2x more than normal. So it should be because the normal is about 35 to 45 and heparin drip PTT should be about 60 to 80. And this is drawn every 6 hours, and that's how often they get titrated. Well, it depends on the policy, how what algorithm you guys follow. If you get a heparin drip question, you will get an algorithm to follow, or it might just be like a question like, person's on heparin drip and their PTT is 70. What do you do? And you're like, oh, wait, that's normal. Don't worry about it. You're okay, sir. Or something like that, right? Why do we worry about the platelets? The hit, yeah. So platelets are assessed um, due to risk of hit. So that's the heparin-induced thrombocytopenia. Cytopenia. Usually, yeah, basically a bunch of bleeding. That would be platelets usually under 100. That's when we look at that one. Think about that one. Signs and symptoms of bleeding. So, bleeding on the floor, bleeding from the IV site, bleeding from the gums, internalized bleeding. So, if you're assessing for bleeding, think about stuff like IV site, gums, on the floor from their stool or urine. Yes, so the abdominal girth thing comes again, swollen belly, and that's where your Turner sign, colon sign, Fox's sign, whatever sign. And if for some reason the semantics on the names comes up, C for the C around your belly button, and then to see the Turner, which is on their flank, you have to turn them. That's how I remember it. And then Fox's is like groin area, so maybe he's kind of I don't know how you would think about that one. Um, but yeah, so what is the antidote for your heparin? Do you guys know the antidote for heparin? I know we all know the antidote for Coumadin at this point. Yeah, it is the protamine sulfate. Very good. Anything else that you think is important when it comes to knowing the heparin? It's actually in this picture right here. How is heparin given other than it's on the pump? Yes, you need to run it separately. So must be run on its own line. Nothing else can infuse with it. So this person should like make sure that this person has two IVs or a central line because you don't want to have that one line only taken up by heparin and now they essentially don't have an IV. And if something happens, then like you don't have a line. Like I always tell about the seizures and stuff. Like if they don't have a line and they go status epilepticus and you need to give IV benzos, sometimes it can be hard to put a IV in, and then now imagine doing that on someone that's like actively seizing. So that's what I always think about there. And then in terms of the math, again, that will be done through an algorithm that you'll get. Um, but yeah, we can talk about the Coumadin bridging a little bit more. So it's soft yes. So all the good stuff. All of the good stuff. Oh, the green leafy vegetables is more for Coumadin because that's just kind of the specific way Coumadin works. But for heparin, I don't think the green leafy stuff matters as much because it's inactivating a different type of thing. It's like activating the XA, Coumadin's doing some other function. But the main important thing is that for Coumadin, you're starting at this. If someone's going to get bridged into Coumadin, and Coumadin is not that common anymore, I don't think I see it very often. I think I've only seen it. I think I've seen it one time for someone with AFib. I see Eliquis more often now. And I've seen it with someone that had a mechanical heart valve. Yes. Although I was picking up my meds and I heard someone picking up their Eliquis and that stuff is like $700. I'm like, oh my God. And Coumadin is cheaper. Like, I ain't paying $700. I'll take my chances. I know. Yeah. Cool. Cool. So yeah, when it comes to Coumadin, we have the monitor the INR. So the INR should be um when on Coumadin should be 2 to 3. That's the therapeutic range. And the antidote, I know you guys know this, and he's mentioned it, vitamin K. And for emergencies, we can give fresh frozen plasma because we know that that affects the clotting factors and not the platelets. When it comes to education, you guys been talking some stuff, good stuff here. So soft bristle toothbrush. If you want to let them know that, how do you know if you're feeling like maybe you're bleeding and stuff? Stay hydrated is a good one. Hydration, yes. So the 2 to 3 liters a day kind of thing. That's just general. We did talk a bit about the vitamin K. So if they're on Coumadin, if on Coumadin, it should be consistent vitamin K intake. So I think he mentioned like, don't go eating a salad or something like that. Oh, ginger, yeah. So a lot of the herbs and how do you call them? Herbs and what's the word for like the non like the non-medical treatments? The G's, yeah, the G's, like yeah, the herbs and herbal stuff. So a lot of the ones that start with a G end up causing being kind of like natural anticoagulants, so they can increase yeah, ginkgo, ginseng, ginger, John warts, yeah. That one does everything though. That one affects everything apparently. Interacts with everything. Yes. So pretty yeah, just keep in mind all the G stuff. I guess he specifically mentioned garlic too. Garlic, ginkgo, ginger. Guess I'll do that. If I'm cumining, avoid garlic, ginkgo, ginger, ginseng. All the G stuff. It's conveniently all G stuff, which is nice. And yeah, avoid over-the-counter herbs and stuff. John warts, whatever herb. What do I call them? John warts something. Root? St. John's wort. Okay. What's a wart? I'm thinking of like the A one. A wart with an A. I'm like, what? Why do you got a wart? What does that even look like? Hold on, I'm trying to look this up. Oh, that's not what I expected. Huh. I was expecting like a root, honestly. Interesting. That's pretty cool. Oh, that's the word I was looking for. Holistic. Like the holistic stuff. That's the word. But yeah, that's pretty much the main thing. Prevention is focus on preventing, probably. I think it's just for general. I think it's just general stuff. This is for PE. I forgot we were on PE at this point. Basically, you're focusing on preventing DVT. A lot of DVT stuff. And you have a lot of different stuff that you can do when it comes to, I guess, general PE. At some point, I got lost in the sauce. So how do we do that? Yeah, so things that prevent DVT would be ambulation, yeah, moving around. SCDs, yes, I like the foot pumps because I know there's people that don't want to get up, they don't want to get SCDs, so tell them to just do the isometric. You can do like the bicycle kicks in the on the bed. Is that what they call it? Bicycle kicks? Kind of just literally like pretend like you're on a bicycle while you're on the bed. That way you can move your legs around and stuff. You can elevate the legs. Um, and stuff, elastic hose, Ted hose, good hydration and stuff. So all the stuff you've been talking about comes up a lot. Be careful with your, yeah, 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 yeah. Yeah. Move around the plane. Um, Caution with birth control pills because of the estrogen causes, I guess people on HRT probably, I guess, because it's also estrogen, right? I'm not actually sure. It's estrogen. I think they get it. I think that's estrogen usually. But yeah, that the hypercoagulable state and stuff. So that's good. So all the stuff uh when someone has a DVT. But now, what about now if they do have a DBT, what are the things that we are changing of when it comes to the above? Guess another way would be foot pumps, leg massage, yeah. Yeah, I remember the Coumadin is really slow. So once they actually have an active DBT, what are the things not to do? I think you meant for here, sorry. Um, yeah, like Coumadin, Lovenox, heparin. And the subcut is good for the DBT, but the drip is good for the active. Heparin doesn't last too long. It's not very active in the blood, which is why it has to be a consistent drip. So I think maybe like 30 minutes after heparin is stopped, it stops having an effect on the body. Yeah, so essentially, um, so here's something that I found interesting, and I was really stuck on it when he mentioned this. In his PowerPoint, he mentioned to not take off the SCDs, and what I think he meant by that, oh, I don't know, because a lot of you guys kind of were set on removing the SCDs, so I was wondering about what nuance. Yeah, he did say remove. Oh, he said to remove on yours? Okay, that's weird. And ours he said not to take them off, but I think what he meant. I think he said don't take them off. And then I was confused personally. So I was in like the rabbit hole trying to figure out what he meant by that. What I think, because I thought in the audio he said to, that's what I was thinking. Yes, that's what I was thinking. Like I was thinking you turn it off to prevent the contraction, like the little pressure, but you would keep it on so that you don't accidentally like dislodge something because it's still the SCDs technically are still applying pressure and maybe keeping if you're removing it, you'll be moving the leg and if maybe there's some slight pressure on that leg because it does cause that swelling, maybe by taking them off you dislodge something. So it would just be like turn the SCD off, but don't remove it. But that was kind of iffy on that one. But I think that's what he meant because I remember being confused on that, and I'm pretty sure that audio has not been changed in 10 years. So it should be the same audio. So yeah, I would maybe clarify if you can. Although I don't think you guys are with them tomorrow, huh? But I don't think it came up particularly. Like that specific thing didn't come up, I don't recall. But I remember being confused and trying to figure out what the rationale was. Because other sources say, um, I just got different things from different sources. So I won't include it here, but that's kind of, I think what he intended was that you turn it off, but you don't remove. But I guess you guys are saying the audio he said to remove. So now I'm not sure. Maybe he said it in class. I don't remember. Yeah. Yeah. Which would be the reason you turn it off. But I guess if you are taking off the SCDs, you'd be, taking the Velcro off and then having to technically move their leg. And at that point, it'd be like you might as well just keep the SCDs on with it being off, so you don't risk moving like the clot around. Probably, I think that'd be the safer thing to do. Um, But yeah, that's kind of that. Any questions on pulmonary embolism? So if you had to talk about some things to focus on it when it comes to PE, the assessment for sure, that's going to be probably like the big thing. Understanding the difference between a fibrolytic and the heparin drip. Definitely, it's going to be a lot on your education when it comes to, I mean, the prevention when it comes to like what stuff causes DBT and your risk factors as well. And your obviously your manifestations, but your risk factors is what I think is like really big for this one as well. All right, we're almost through with this one. Almost done, almost done. So then we're going to talk about the pleural space because there's a lot of stuff here that kind of deals with the pleural space. So the pleural space is like a little tiny little, how did I pass it? Wow, that's crazy. This little area that has a little bit of fluid so that the lungs are able to slide back and forth to reduce friction. So you're not really supposed to have anything more than that small amount of little, I don't know if it's surfactant, but it's some sort of a little bit of like like, a little bit of that fluid to reduce friction and allow your lungs to expand better and stuff. Um, but then some of the conditions, like a pneumothorax slash a hemothorax, this is caused by air or blood in that space, when it shouldn't be naturally. And having stuff in that space, is taking up space, so it limits how much your lungs can expand. And there's, different types of pneumothorax. There's also the tension pneumothorax, but you don't worry about that one for this class. But what we do want to worry about is how do you diagnose a pneumothorax or slash a hemothorax? So this is something you guys should know. Yeah, the chest X-ray, and maybe also your ABGs as well. But definitely the chest X-ray can tell you a lot, which is why we do the chest X-ray when we're putting in a central line to both confirm positioning and assess for pneumothorax. And what are your signs and symptoms? So this can be really similar to the PE. There's a lot of similar stuff. Yep, the shortness of breath for sure. Shortness of breath, chest pain for sure. Yeah, hypoxia, so they're desatting, compensation stuff. So you'll see tachycardia, tachypnea. So that's why it's very similar. But the PE will typically not have it will not have hemoptysis, so you will not see. So there's some things that you will not see, and I'll kind of put it here. Yeah, you can have reduced absent. Yeah, you can have reduced absent lung sounds on the affected side. I would say diminish absent lung sounds on the affected side. I think the only thing I don't even know if it goes over tension pneumothorax, but the trach deviation that's related to the tension pneumothorax. That's a huge medical emergency, and you have to place a chest tube immediately. But I think at most that you will have to know. But tracheal deviation is tension. Um, if tension pneumothorax, and I don't think you need to know much else about it. This is a medical emergency. Chest tube immediately. So there's some things that I think these are some things that I think came up in the one of his like in class SATAs. Maybe did it? Like you have I think he talks about this, the paradoxical breathing. So the paradoxical breathing is something you will not see. That's more of a tension pneumothorax. So if it comes up in a SATA, don't click it because it's not for your pneumothorax. So maybe let's talk about it here. So things to separate because you're not tested on tension pneumothorax. So some things that can paradoxical breathing. Oh yeah, select all that apply. We all hate them. So again, you're not going to get tested on tension pneumothorax in terms of signs and symptoms. So if you're just being tested on a normal pneumothorax, paradoxical breathing is not one of the answers because that's tension. You will also not see hemoptysis. That's pulmonary embolism. Yeah, they usually. One of them said SATA instead of select all that apply. Yeah, but yeah, I think another one that came up in the multiple choice was like one of the choices in his in class lectures was like hemoptysis, and that's not one of the right answers. Hemoptysis is pulmonary embolism, so don't get confused with that. Something else, the chest pain, the pleuritic chest pain stuff. Yeah, so don't get confused by that. If it comes up, I don't even know if it's gonna come up. I don't recall. Uh, 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 so what is our management for pneumothorax, hemothorax? The main one. Yeah, the chest tube, in order to drain away some of that air and blood, respectively. If it's small, it can go away on its own, but we're also going to do, assessments that make sense. So O2, uh, lung sounds, how, like, patient effort. Oh yeah, the effusion, yeah. There will be pleuritic chest pain. That's what this is. I'm saying there's no paradoxical breathing because paradoxical breathing is tension, and you're not tested on tension. Yeah, it's kind of like, yeah. I mean, I guess you can have needle into the pleural space for depressurization, but it's not. Yeah, yeah. Maybe we can see a video of that. Yeah, so it's called paradoxical because it's basically the opposite of what you would expect. Yep, it's pretty crazy. It's pretty crazy. The craziest thing I think I've heard about was when we were in the peds. I can't remember the name of the condition. I think it. I don't remember if it came from. No, not from tetralogy of Fallot. It was like one of the like little extra holes in the heart where depending on what happens to the person, they can have like their blood flow reverse, like go in the opposite. I forgot the name of it. That's like the craziest thing I've ever heard. Your your blood flow literally reverses. That shit's insane. Let's see if I can find it. Pediatrics, blood flow reverse. Ba-ba-bum, ba-ba-bum. Yeah, it was like a specific name, but I can't remember what it's called. But oh, Eisenmenger, that's the name. Yes. Eisenmenger syndrome. This one's crazy. Let me see. Yeah, I don't know. This one's crazy though. I can't remember the specifics, but it's pretty crazy. I think it's the reversal of the shunt, but yeah, whatever. I'm getting out of topic. But yeah, that's basically it. Paradoxical because it's not how breathing normally works. It's the opposite. But yeah, that's pretty much that. When it comes to this, it's pretty simple in terms of that. Pleural effusion, that's the abnormal fluid collection in the pleural space, as opposed to pulmonary edema, where it's the fluid is either in the lungs directly or it could be in some interstitial lung tissue. So with this one, that's where we get the thoracentesis as one of the managements to put the needle and directly drain the fluids away. What are some potential causes of pleural effusion? Did you hear a pleural rub? So I think the pleural rub, you might be able to hear it. The pleural rub, I know you can get that with like endocarditis and cardiac tamponade. I'll look it up here. Because that's usually the sound of the does no typically you not hear a pleural rub, so because the pleural rub is usually the I think the heart um I think it's usually the heart rubbing against I guess the I mean I guess if it's like a bunch of fluid it might stick out and do stuff, but yeah, it says no for less likely. It's a good thought though. But where are we? Oh, we're here. But yeah, we said potential causes. What did you guys say? Said pancreatitis. That true? True? True. That's immediately at the top of your heads because you guys just had the test for that. Yeah, that could be a potential thing. Other things can be like maybe like a heart failure, like some cancer trauma, um, maybe like inflammation stuff from like TB or something. Yeah, so you can have pleural effusions, maybe some cirrhosis and stuff, third spacing. But same thing, you just get rid of the fluid through the thoracentesis, which we'll talk more about here. And then the empyema, which is the collection of pus in the pleural space. This one can be caused by things like pneumonia and stuff, infection stuff, and management is just chest tube. Again, very basic. All of these stuff is a lot of them is chest tube or pleural effusion with thoracentesis, which we can then talk about here. So this is, we talked about the procedure to remove the excess stuff using the needle, relieve the symptoms, blah, 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 improve breathing. So just the very basics. What's the positioning for a thoracentesis? How should they be positioned? Yeah, so sitting up and leaning. Yeah, you will help them prep them up. Some typical stuff that at this point we've hammered in really hard. Be respiratory status, if there's been an infection after, because you know you're inserting something in. If there's bleeding or like excessive bleeding, bruising, you want to do a chest ray before and after. Makes sense. You want to see how your intervention actually helped them. Take into account that you are taking away fluid after, so you want to think about how that affects perfusion and blood pressure and stuff. Complications of this, probably like a pneumothorax. Had some patients in the hospital that I come like I read the note and it was okay, they're gonna go for a thoracentesis by the end of the day. I didn't get to see it, but then I come back the next week, the same patient's there. I have um different nurse but same patient comes up again. And then I check back on reading their history and they got a pneumothorax from the thoracentesis. So stuff like that. And post procedure, just stuff for you to look at. You know, collect drainage bottles, document more assessments. Good lung down essentially is what this is. So if it's unilateral, then good lung down, the head of the bed up, chest X-ray. Any questions on this one? That's decently basic. Decently basic. Oh, I didn't realize I was muted. I don't know what was the last thing you guys heard? Thoracentesis, decently
before you
basic.
started scrolling.
Oh, okay. Decently basic. Yeah, 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 this is decently basic. I think I was just saying we're doing pretty good on time. Chest tube is just kind of written stuff, a little bit of fill-in. ABGs is just a little bit of fill-in. It's pretty basic. You just have to interpret it. I don't even think you have to know the compensation part of it. You just have to know how to interpret it, which is pretty easy. But if anyone's having trouble, we can help you out as well. But yeah, we can move on to chest tube. So that's the one I see the most is this one actually. They have this one at the hospital I'm at, or I was at for clinical. I had a patient that had two chest tubes. I did not say yes or no. I don't recall, but we went over it in yesterday's. But yeah, this is what this is gonna look like. This is the drainage chamber, so not the best picture, but essentially this is where it's gonna fill up here, right here. This right here is the water seal, so it actually here you can't really see it at all, but it has like these little grates, and I think he's come into clinical with a chest tube, right, and kind of showed you guys. If he hasn't this last week, then he'll do it this week probably. Well, he probably will do it, but you get to see the chest tube, and these are disposable, so after it's done, you just kind of throw it out. But yeah, the little water seal thing here, maybe we can get a better picture of the atrium. That's the one I know better. Atrium, chest tube. Is it a good picture? Probably a good picture. Eh, that's not bad. Okay, cool. So this is how you're gonna see how much is being drained out. Here, I don't recall, but I think B is your pressure. So B is how much pressure, and I think typically it's like 20 or so. Here it would be your water seal. So here you see like this number 1, 2, 3, 4, and 5. If I believe, if you start seeing bubbling, so the bubbling on the water seal, that's the purpose of the water seal is to show if there's air leakage. So you might see bubbling, um, or if you see bubbling, that's indication that there is some water leak, air leak somewhere. But the numbers here, I think, represent like how bad that air leak actually is. So from 1 to 5, it gets worse if there's leakage, and so you have like minimal air bubbles. So maybe like minimal air bubbles, they kind of just go on number one. As you have more air leakage, you have more bubbles coming out, and they start filling up more of the space. So that's how you know there's a worse air leak, essentially. Josh says that's when you clamp it. Yes, so that's when you would clamp it. If you see bubbling in the water seal, that means that there's an air leak. But you will also have this right here would be your, I guess this is an older model, not exactly how the one I saw looks like. Let's see, there's this is the one I'm more familiar with. So, but it's like relatively the same idea, is that you also have a suction chamber. Damn, that's expensive. I guess is this a reusable one? I don't, if I recall, they're disposable. I guess they're just that expensive. Ooh, cool. So here would be the suction chamber. Well, let me actually see if blah blah blah. But isn't intermittent bubbling okay? It just says that the lungs are still filling, then continuous bubbling is bad. I think so. There's some places where yeah, so titling is different from the titling would be different from bubbling. Bubbling is literally like you literally see bubbles, but titling is just kind of like think of the tide in the like the like like the waves like in the ocean. So it's gonna go up and down. So this will have some this can have titling, which is just moving up and down. Yeah, I think that's correct. So because yeah. So maybe you'll have a little bit. It's more like, like long term, like looking at it. So in the beginning, there's a lot of different. there's a lot of different things that apply in the beginning versus like longer term treatment. So um maybe early on you could have some bubbles here in the very beginning because you're getting rid of all the main stuff that's in there at the start. So you'll probably you'd see a little bit more stuff happening here. It's more about like later on, like as you're monitoring them because they're gonna be on this for a little bit. So like maybe like 5 hours later, you still see like you see air bubbles happening here. You know there's an air leak. Yeah, so bubbles are also yes, so bubbles are okay in the suction chamber, but not the water seal. So you can see bubbles in the suction chamber. So that's what they're different. The water seal is this one, and this one bubbles. You don't want to see continuous bubbling. Maybe like a bubble every once in a while is fine, but continuous bubbling is bad, and it might be different when it's first placed in. Maybe I'm not sure what can affect that, but yeah. But the suction chamber here, if it has bubbles, that's nothing. There's nothing wrong with that. But you can see titling. So the titling would be with breathing in and out. So it would move the water up and down, kind of goes with the breathing pattern. The fluid here would go up and down, like with the breathing. Jessica says, how would you know if the pneumothorax just hasn't resolved? Maybe comes a lot with the patient condition. How are they reacting? Maybe we're gonna do continuous vital signs and stuff and see what's going on. So the bubbling continues. I see what you're saying. The only times I've ever worked with them, it's always been like the patient had a chest tube like a few days ago, so I didn't really see anything. So I don't know exactly how it looks like in real life when it's first placed in. But yeah, that's a good call too. So patient condition, chest X-ray to see what's going on. Patient condition probably tells you a lot just to see if they're in distress and they're sad too. And mhm. Hmm. But yeah. So if we can go back to here. So here's what I wrote down here. Suction control, don't worry about the suction control part. That's a suction chamber. We expect there to be some bubbling in the suction. So back to this picture. This is a suction chamber. We expect to see some bubbling happening here, but the ones that are marked here, we don't want continuous bubbling to be occurring here, uh, because that could be a sign of an air leak. Oh, apparently I wrote this already. Once there's no more bubbling, it should signify the pleural space is now closed. Just X-rays done to confirm this. And this is in the suction. So we expect bubbling in the like gentle bubbling in the suction chamber, which is this one. So don't confuse the suction and the water seal. Let me know if you guys are confused on that. Water seal, you're assessing to look at for air leaks. The suction chamber can have bubbles, and that's expected. If the bubbling stops here, it could be that the stuff is done. So the water
I'm
seal. Oh, go ahead.
sorry, it's just because I didn't want to type too much, but I'm just a little confused because I'd like to think ahead and see like how could he ask me a question about this?
Yeah.
So I'm wondering if his question will be specific enough because if it says like, oh, you assess your patient and there's bubbling in the water seal chamber, I'm assuming it'd be like, oh, what would your action be? But so it's like normal in some cases, but not normal in some cases.
Um, I mean, I think in that scenario, you would have to, like I said, like it's water seal. Probably you can expect it to happen in the very beginning, but anything past that, so a lot of those questions, they're wanting you to clamp in that scenario. Like the basis of the question would be to for you to be like water seal bubbling and water seal not normal, do something. So you just gotta keep in mind water seal versus suction, the suction chamber. I don't know if that helped with the question. I get the concern though. I get what the yeah, continuous bubbling. That's not a bad thing, yeah. So continuous bubbling means that stuff's happening. but that's suction chamber versus water, the water seal chamber. So don't get caught up on that. So just know water seal bubbling, probably an air leak. Bubbling and suction control, normal, expected normal. Especially if it's like gentle bubbling, continuous gentle bubbling in suction chamber, expected and normal. Continuous bubbling in the water seal, outside of like very initial treatment. And I think he might have said like literally very, very initial treatment, like quite literally at the very beginning, and then it'll calm down. Not normal in the water seal. Is that more clear at all? Okay. So again, water seal, we don't want bubbling because that means that there's an air leak. And the basis for a lot of the questions will revolve around that. So no, there can be some nuance to this, but the basis of a lot of those questions are the assumption that we're getting rid of that nuance and we're just saying bubbling water seal bad. And that's where they try to trick you. Maybe they'll have a question where it will be like there's bubbling in the suction control, and they try to get you because you confuse water seal with suction. So that's some type of potential questions that you might get would be like, there's bubbling in the suction control. What do you do? And it's like, actually, that's expected. Versus there's bubbling in the water seal. What do you do? Right? But then when there is bubbling in the water seal chamber, the thing you need to do is clamp it near the patient's side and then look back at it. The concept here would be you essentially get rid of the connection to the patient. So if there's an air leak on the patient's end here, so if there was a leakage on the patient's side, then the bubbling will stop because you essentially disconnected the patient from the system. The system no longer can detect an air leak because the air leak is patient side. So, but if that bubbling in the water seal continues, even though you've disconnected the patient, that's essentially telling you that the air leak is actually coming from the system side because you took away the variable of the patient and it's still happening. Does that make sense? Because I know he probably confused a lot of you guys because he said the wrong thing and then it's like, never mind. Oops. So that might have confused people. So here I wrote clamp near the patient's side, assess the water seal. Bubbling stops means the air leak is patient side, and then you have to call the surgeon. But if you clamp near patient side and the bubbling continues, you can try to see where the leak is happening system side. Any confusion on this part? All right, let me know if anyone else is confused though. And then another thing that I don't know if I mentioned it here. Another thing that's important is if the chest tube gets disconnected, you gotta do what? From the patient, rather. Yeah, you gotta hit them with that impregnated gauze. Gotta hit them up with one of those. Yeah, yeah, yeah. What do they call it? Yeah, yeah, yeah. What's the name of the chemical that's in it? Is it the Seroform? Is that what it's called? Oh, the Vaseline. That's what it is. Vaseline impregnated, and then call the doctor or rapid, whatever. Yeah, do not try to reinsert the tube. There's also other types of dressings you can use, but not need to know. Sure. I think just Seroform if that ever comes up even. All right. So in terms of monitoring for this, it's every hour according to what he mentioned, I suppose. And additionally, how much is considered too much drainage? How many ml per hour is too much? 70, yep. So if it's more than 70, we're concerned. When else are we concerned when it comes to drainage? I mean, if it's a hemothorax, it's expected. But if it's the pneumothorax, then I guess it's be like, okay, that's kind of weird. Yeah, so we already mentioned if it's too high. Is there any time where we're worried if it's um too low, or if you get what I'm saying? Yeah, so basically what I'm getting at is you're not just concerned if it's above 70, but you're also concerned if it spontaneously stops draining. So if you're consistently, why is it concerning if it's above 70 ml per hour? That's a great question. I actually don't know the answer to that. But apparently that's when it's too much drainage. Maybe if I had to guess, maybe it caused some sort of irritation and bleeding. Yeah. Like maybe it irritated it too much, caused internalized bleeding, and now it's hemorrhaging. The hemoglobin's coming out. He's hemoglobining out. But but yeah, you're also concerned if it spontaneously stops draining. So if it's going from like a consistent flow and then it suddenly stops, you're concerned that there's some sort of uh some sort of obstruction. Um, could be obstruction, DC, um, or whatever, right? So that's what you're concerned about. Yeah, that makes sense. Yeah, yeah, yeah. Could be indicative of hemorrhaging. So yeah, and if they have a pneumothorax and then you're seeing bloody output, that's probably also not a good thing, right? Because that wasn't the original issue. So but if it's a hemothorax, then you expect there to be blood. But then you're still worried about if the output's too much because maybe yeah or whatnot. How about the bedside? You need clamps and gauze. And similar to the Foley catheter, you should remove it as soon as yeah, two clamps, the two Kelly clamps, or the whatever they're called. Either remove it as soon as it's no longer needed, just to prevent risk of infection. If you don't need it, you don't. If you don't need something invasive in you, then gotta get rid of it. So I don't know if you mentioned this or if I looked this up on my own, but I wrote down, if your drainage has been less than 200 ml in the span of 24 hours. Lungs have been expanded. They looked at lung sounds are good. Condition is good. Maybe they did a chest x-ray. Um, then we can consider taking them off. They might be placed off the just water seal, so no suction. So they'd be on the chest tube without any suction. So that's what's called being on just the water seal. And they'll be like that for 24 hours to see if they have return of that the issues with the pleural space again. So if they had a pneumothorax and it seems like they were improving, and so we took them off the suction. And then 24 hours later, we do a chest X-ray, and they got pulmonary edema. They got a pleural effusion again, not pleural effusion, sorry, and they got like more air, like the pneumothorax came back, like the air is back, or they have a hemothorax, and we got rid of most of the stuff, took them off suction, and now it's back. Then we know that they're not tolerating being off the chest tube. But if they are, then it comes off. And he emphasizes not to strip the tubing also. He says it's not in our scope of practice because it could cause certain complications. But when the doctor does it, he's got different finger techniques, I guess. That was a question for our class as well. So as far as I know, they consider milking, and it might be the same in literature. They consider milking the tubing as in kind of like taking your fingers and kind of just uh how do I hold on, let me just turn my camera on and do this. Hold on, let me see if I look presentable actually. Bum, bum, bum. Whatever, I don't care. All right, let's turn the video on. I don't even know if you can see it. You can even see the video? Not really, because I'm screen sharing, huh? All right, let me stop screen sharing. Okay, so here I am. There's my fingers. I guess milking would be like going like this on the tube. Like this on like a clot or something versus like like pulling on it. Like that's stripping versus milking is like this, I guess. We were very confused on this as well in class, don't worry. Yeah, stripping's more aggressive. Yeah, we can milk, I suppose. Although in my brain, the stripping motion is milking because that's how it looks like, kind of, right? When they're milking the cow. But yeah, stripping is more aggressive. Stripping is like you're like crazy stretching. Yes, 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 yes. Yeah. So apparently it's not in a scope of practice, but the doctor can do it because they got magic fingers. Yeah, any questions on this? There might be a lot of questions on this one. In terms of from you guys, not from like the test. I don't recall. But I meant like because I know it gets confusing because you we don't see these too often and yeah. So I would say the main thing is knowing what you need to have at bedside. Definitely knowing about this right here, the gauze, applying the sterile gauze if this ever comes off, understanding the difference between the water seal and the suction, how much is too much drainage, and also you need to be concerned if it suddenly stops giving you any output. Is a burning pain in the chest normal? The book mentioned it. So actually, this was a question for us in 220. So, so the burning pain, I would say if someone has that burning pain, it could be considered normal, but I think the way the question they asked in 220 was, what do you do if they have that burning pain? And the answer was just to like assess their vital signs, see if it's yeah. So that's the thing. The book says to reposition the patient, but the question wanted us to put like assess vital signs just to see if the patient's having any conditions, which I guess makes sense. But that was like my thing. I was like, God damn it, the book says to reposition. So I clicked that, but they're like, well, check your patient first. I'm like, I guess so, but whatever. But yeah. Um that was a 220 question. So I don't think it's gonna come up again. Fair. Fair enough. Any other questions on anything? Okie dokie. Lots of people trauma bonded in that class. All right, low key, I like 220 better than 222. I don't like OB. Well, I OB grew on me, but I hate peds. Oh my God. Yeah, I mean, if it's a hemothorax, then that should be fine. Just I mean, think about hemo versus pneumo. If it's a hemothorax, then that's expected. If it's a pneumothorax, that's not really expected as much, because pneumothorax is air and hemo is blood, so that's kind of a distinction to keep in mind. So it's not like fully black or white. there's some nuance to it, I suppose. What are islets? What did you mean by that? Let's find out. I have no idea. Don't worry about it. I'll say that much. Yeah, don't worry about it. I don't even know what this is. Yeah, don't worry about it. Look, I'm sure you'll get more training on it at some point. Set to immediately notify the helicopter if you see islets on the chest tube. What in? I don't even know what this is. Yeah, I have no idea what that even is. Almost looks like a cap of some sort. Yeah, I actually have no idea. But yeah, don't worry about it. Low key, Mr. Robbins just kind of does his own thing, so the book is not as important. Yeah. But if it helps you to read the book, then by all means. But you don't need the book. Ah, cool. I don't even know where my book is. If I'm being honest, I haven't touched the book since 212. I was trying to read a chapter and I think I spent like 2 hours trying to read like 3 pages because I just cannot. I think like my ADHD is too powerful. It couldn't handle it, so I stopped reading it. I think it's kind of like I read a paragraph and I'm like I don't understand it. Like I don't like absorb anything from that information, so then I have to reread the paragraph and then I end up reading the same paragraph like 20 times and then I get bored. Yeah. One time I had to read a book, like a book for class, like in an English class, and I spent like 2 hours reading like a 20-page chapter in the book. And I don't even think I actually absorbed any information from it. Yeah, the pH for this one 35 sorry, the value is 7 point. Sorry, my brain is fogged. 7.35 to 7.45. And the PCO2 is also nice because it's the same value. I should probably put this one first. You don't worry about as much about the O2, but the O2, just for reference sake, PO2 is 80 to actually I think is it 60 or 80? I think it's 80 to 100. Yeah, and then this one's 22 to 26. And 60, I'm thinking of intubation stuff now. But yeah, that's the values. So that's kind of what you go with. So when it comes to CO2, CO2 is considered an acidic. So acidic. So when it's high, it's acidic because that's its attribute. There's a different. I think there's like I can't remember. Like there's like a shorthand way. I don't know what it was called. Was it called Rome? That might be what it's called, Rome. But I don't know how to use that. Yeah, Rome. So that can help for some people. I think there might be videos on how to do it. Maybe like Nursera has it. Let's see. Nursera Rome. I'm sure that yeah, the Rome method. Yeah, so if you're having issues with this, I think this is a good video for it. I kind of just raw never mind. I was gonna say a word I shouldn't. To say raw dog. I kind of just like look at the pH and then I just look at the values and just try to match and then I just kind of do it. So when this one's high, it's acidic. When low, it's basic because it's less of its attribute. CO2, this is considered a base. When high, it's basic because that's its attribute. When low, it's acidic because that's its the opposite of its attribute. Yeah, the tic-tac-toe. What's the tic-tac-toe? Yeah, I just look at pH. I go, this is basic or acidic. Then I look at CO2. Is this basic or acidic? If it matches, I found my match. Look at the third number. If it doesn't match, look at the next one and see if it matches. That's kind of just what I do. Yeah, but if you need it, that I think the Rome method apparently is pretty good. But that's the general idea. Any questions on this part stuff here? Okay, so basically, kind of like what I do then. I guess is what I guess I do the tic-tac-toe essentially. Yeah. So here we can talk about um information here. Again, you don't need to know how to treat it or some of the signs and symptoms. At most, you would be really just interpreting it. I do have information on this. Let me see. But it's super extra and you don't need to know it, so maybe I don't even mention it because it's super extra. Yeah. So I do have a thing here on how to read it. So at least this is how I do it, but I can link this video should be pretty good as a way to read it. So maybe we can do this for people that could use that video. Otherwise, the way I do it is I literally just read I look at the pH first, determine if it's acidic or basic. So remember that um, above 7.45 is basic, below 7.35 is acidic. Um, so I determine that first, and then I literally just look at the next value, determine if it's basic or acidic. So in this case, if I find a match, then I can already start looking at respiratory versus metabolic. Um, because CO2 kind of is acidic and representative of respiratory issues, while this is base and representative of metabolic issues. So if I have a match with my pH and my CO2, I know it's respiratory issue, and then I know if it's either basic or acidic because I found the match. If I have my pH and I have a match with bicarbonate in terms of basic versus acidic, then I know it's a metabolic issue, and if it's basic or acidic. From that point on, you then look at the third number, whatever the third number is, and determine if it's acidic or basic. Um, if it's if this number is the opposite, so if I guess I just probably need the numbers. I don't know if I'm confusing anyone. Essentially, you look at the third number. If that number is within normal limits, then there's no compensation at all because it's not abnormal. But if this number is abnormal, then you know that there is some compensation. That's partial compensation because this number is abnormal because it's trying to compensate for the change in the pH. When you have um complete compensation, you will actually see it in your pH because your pH will actually be within normal limits. And in that scenario, the way you do the matching is by splitting this number in half. So essentially, whatever number you have, let's say your number is like 7.4 or 7.37. It's within normal limits, but it's closer to the acidic side. So you consider it acidic for in terms of matching. So you would consider it acidic. And something I was saying in during Kalen's session was that you can have the pH match both the bicarb and both the CO2 and the bicarb, which is something called like mixed acidosis, mixed alkalosis. So um, in that scenario, that means that that person is having respiratory acidosis. Like let's say this number again, this number was like let's say you had pH, God damn it, pH of 7.37, a PCO2 of 58, HCO3 of 16. This person would be having an acidic pH, an acidic CO2, and an acidic um, bicarb. This is what's called like a mixed. This would be like a mixed acidosis because this person is having both respiratory acidosis and metabolic acidosis at the same time. But that's you don't need to know that. But if you've ever wondered, if you've ever done like random practice questions online and you've seen stuff like this, that's what that's referring to. But for the most part here, you'll instead will see stuff like this instead. You will see this would be like 30 and it's basic. So you would be matching acidic with acidic. Um, and you see that the pH is within normal limits and your CO3 is abnormal, meaning that this would be like respiratory acidosis with full compensation. But for now, if I recall, 232 doesn't even ask you for the compensation. It just wants to know if it's respiratory or metabolic or acidosis alkalosis. So you don't really need to know much more than that. And it doesn't, I don't recall it asking either on interventions or anything. So it really is just interpretation. So I would recommend watching some videos because they do a lot of basic stuff here. Otherwise, this is the explanation I wrote out. If it helps you, cool. If it doesn't, try looking at the Rome method. And here I have an example. So pH of 7.5, so that would be a basic. PaCO2 of 46, so that's acidic. Bicarb of 35, so that's basic. So we can match basic with basic. So we know this is metabolic because it's involving bicarb. It's basic, so metabolic alkalosis. This number is outside of normal limits, so you could say this is a metabolic alkalosis with partial compensation. So let me see with the chat because I kind of ignored the chat for a little bit. Let's see. Yeah, full comp is pH is normal, partial, yes. 7.4. I think you mean like the little halfway point, yeah. Yeah. Like the halfway point. Yep. Any questions on ABGs? Because we could go through some just for fun, but it is pretty much just basic recognition of it. And there are you'll learn the intervention, you'll go over the interventions more in next class. So I do have that information, but I'd rather not confuse people. I mean, it's important, just not for this. Your PaO2 is important, just not as much for this. So that's something that we'll look at for more critical care. No, there's like yeah, it doesn't mean much for one or the other, but it's important for certain other things, like if they're actually getting O2 in, because that can be a reason we might want to intubate them because they're not getting any um, oxygenation. So they might need to be invasively intubated so they can get it. So for example, someone is having respiratory failure, complete respiratory failure. We call a rapid response or something. We try O2 supplementation. It's not really helping. We advance to 100% non-rebreather. It's not really helping. We try Ambubag. It's not helping. We try the CPAP. That's uh not like it's a non-invasive mechanical ventilator, and that's maybe something that we put them on while we wait for the MD to come in and then intubate the patient. So that'd be like at that point like full respiratory failure, code blue. This patient would be intubated, and part of the thing we look at would be the PO2 for that in that scenario. So if the PO2 is a certain number and the CO2 is a certain number, we would try to intubate them. But realistically, probably a lot of the time would be based on patient status because ABGs take a while. And if someone's decompensating that badly in person, you just kind of do it based on how well they're tolerating or not the treatment because some of the things that would cause you to be intubated would be conditions where your alveoli are simply not exchanging oxygen in the blood. So your nasal cannula, your simple mass, none of that O2 is actually doing anything for them because there's a lack of ventilation and perfusion happening. That's another case where the VQ mismatch comes in, which is why we talked about intubation previously, because there's no, the person's ventilating. That means their chest is going up and down, but there's no exchange of oxygen. Meanwhile, um, there's could be other reasons why we intubate, like the person and maybe the person's ability to exchange oxygen in the alveoli is fine, but they're not able to move their lungs up and down. In that case, we intubate, and the PO2 is a thing we would use other than patient condition. But that's kind of the idea. So maybe the ABGs and the PO2 would be more looked at if it's kind of like maybe like a slow progressing case would they need to be intubated, but if someone's like acutely needs it, it'd probably just be based on condition. But basically the point of all of that was to say that it's an important value, but in terms of this class and the questions you'll be asked, it will not matter. So I kind of just yapped. That's pretty much it. I mean, I don't really have, I mean, I could put stuff here, but again, it would be extra information that you don't need. So I don't want to confuse anyone, but it could help for the next class. So maybe I will. I don't know, vote on it in the chat real quick while I look for it. Oh, well, actually, I don't know why I did that. Do we have the same time as the final for this exam? You should have more time actually, if I recall. Because should we have the same time as the final for this exam? Okay, I read that wrong. I don't know. Should have enough time though. You talking about the final for the 2 hours? That sounds about right for the final 2 hours. Oh, you meant like start time. Okay. I thought you meant like total time that you can spend on it. Oh. Oh, that's a lot of time. Should be okay. Did you do much heparin? Not really. I don't recall it, but I don't think I don't really have an issues with the math, so maybe if I saw it, I was just like, oh, okay. I didn't really think much about it. Here, I'll do this. Not on test. I'll do this. I'll move this out of the way. So if you want extra information, I can give you extra information. And if you don't, you can ignore it. Even this is a little bit extra information because we already talked about all that. So extra information not on test. But don't worry about that. About what I'm about to post. All right, so none of this will be on the test, but here's some extra information if you care about this. You probably don't, but I'm posting it anyway. So respiratory, lung, CO2, we know that. We know respiratory compensation is faster. It's less effective long term, but it works faster. So it starts having an effect faster. So for example, if you're having metabolic acidosis, so think about DKA. We know that one of your signs of DKA is the Kussmaul respiration. So in that scenario, you're having your respiratory compensate for the metabolic by trying to get rid of CO2 by hyperventilating. And even though it's not going to be not too effective over the long term, it is fast acting. So that's probably this part is the most relevant part to your class for now. But um, even here, there's some extra information. So metabolic is regulated by the kidneys primarily, but your liver and your pancreas also has a impact because your pancreas creates bicarbonate, and your liver also breaks down lactic acid. Um, and the metabolic is more effective at controlling your acid base, but it's also slower acting and will take much longer than your lungs. Then here I have some, again, very extra information on respiratory acidosis, alkalosis, metabolic and stuff. So I have, for example, potential things that can cause it here, ways to treat it and whatnot. So I think the respiratory one's the most basic stuff. Metabolic is where it gets a little funkier. So here you can have things happen because of gain of acid, loss of base. Again, you don't need to know any of this. Don't worry about it. But if you cared or like if it interested you, I have information here. So if your kidney is impaired, you can imagine that it's one of if any of these three organs are impaired, it can lead to issues with the metabolic side. So if kidneys are impaired, it directly either retains or wastes bicarb. If your liver's impaired, it breaks down lactic acid. So if your liver's impaired, you end up having a buildup of lactic acid and have metabolic acidosis that way. And if your pancreas is impaired, then you have decreased bicarb production. So these are ways that you can have metabolic acidosis. And then alkalosis can be things that lose acid, like NG2 suctioning, vomiting, diuretics, and either that or gain of base, so taking too many antacids. And typically the underlying cause is relatively similar. If I don't think, again, you don't get tested on this, I don't think. But treating the underlying causes most of the time the way most of these are solved. But some other things that can help if you have respiratory acidosis would be getting CO2. If you have COPD, you got to be a little bit careful. That's where the pursed lip breathing come in play as well. Hyperventilating, pursed lip breathing. If you have respiratory acidosis, alkalosis rather, from hyperventilation, anxiety, pain, infection, stuff like that, then that's when that brown bag thing we see in the movies all the time, like people having anxiety attacks and then breathing into the bag. And then the metabolic acidosis and alkalosis, that's where you might probably more likely to take like medications for it. Like if someone has DKA, they're going to get insulin, bolus, and drip. If someone has lactic acidosis, they might have sepsis. So we're going to treat the sepsis. Um, if they have kidney impairment, maybe they need a dialysis and treat hyperkalemia and stuff because that can be associated with some of these conditions as well. Maybe if they have severe case, they can give bicarbonate. And here it'd be more like supplementation and other stuff. But again, not on test. Key thing here. It's just extra info, if you were wondering. Just focus on knowing how to read it. And maybe this video on the Rome method helps too. That's pretty much it. That's pretty much all I got for you guys. Any questions on anything? Oh yeah, you're gonna get both. Don't you worry. Okie dokie. Well, was this exam hard? I'm just not good with respiratory as much. I don't know. I actually felt like I had a little bit harder time with Robbins's questions. I don't know. It just kind of threw me off. It was just very different from what I was used to. But I had a different experience because for me, apparently like I did better. I did like better, or I did how do you say? My best test was like everyone else's worst test. So like the cardiac renal was a lot of people's worst test because of the wording. But for me, I was just like whatever, and it worked. But for this one, people were like, "Oh, the wording's nice." I'm like, I don't know, it's kind of confusing to me. I don't know. It's just like a weird disconnect for that. But um, again, the general consensus was that the general average. I looked at all our averages for the test, and it was like everybody on average was getting from 82 to like 87%. I think our averages. So our average was never under 80%. So definitely very doable and stuff. And those are the files if whichever one you need is a doc or a PDF. Yeah, you too. You guys have lecture in the morning or whatever. Yeah. Oh, by the way, if you guys know what time you guys have lecture on December 5th, would it be if like yeah, I don't know if it would be better for you guys to have lecture at 12 or at because just so, like you guys would be able to attend the event. Okay, so I don't know if it's gonna be in person or not. Um, oh, it's online. Okay, so I don't know. That might make things a little bit weird. Yeah, I don't know. Maybe you guys, if you guys want to, you maybe could try to advocate for a time that works best for everyone, so that you guys are still able to make it to the event on December 5th. Because it'd be better if the most amount of people could come. Yeah, because I know your schedules, it says stuff, but then they never follow it sometimes.